Thanks, Daniela. Good morning, good afternoon, good evening from wherever you're listening today. Thanks to Healthy Smile Happy Child Initiative for inviting me to speak today. So I'm just going to share my screen. Okay. So today I'm very excited to share the results of the findings of our project on how to integrate the Canadian Caries Risk Assessment tool into the primary care of Indigenous children in Manitoba. Before I continue, I would like to acknowledge the Indigenous peoples of all the lands that we are on today. While we meet on a virtual platform, I would like to take a moment to acknowledge the importance of the lands and pay respect to the Indigenous knowledges and wisdom of their elders past and present. I acknowledge the ancestral and unceded territory of all Inuit, Métis, and First Nations people that call this land home. And as a non-Indigenous person, I am committed to actively work against colonialism and towards reconciliation. And so by way of introduction, I would like to remind us of what early childhood caries is. Early childhood caries is defined as the presence of one or more decayed, missing, or filled tooth surfaces in any primary tooth in a child under the age of 6 years. And the more severe form of the disease is termed severe early childhood caries. And in the old times, old terminologies, the early childhood caries used to be known as nursing bottle caries, baby bottle tooth decay, night bottle mouth, night bottle caries, and some other names are being used, but now the term is known as early childhood caries. So why are we so much concerned about early childhood caries? Tooth decay in children is a significant public health issue. As been reported, caries in children is 10 times more prevalent than asthma, but it has received less attention. Early childhood caries is complex, it is multifactorial, it is not only influenced by bacteria, host, or diet, but it is heavily influenced by social determinants of health, such as low socioeconomic status, poor access to oral care, poor literacy and education of parents, discrimination in the society, poor living conditions such as non-fluoridated water areas, policies, and cultural norms. We also know that early childhood caries is highly infectious and it is transmissible from the primary caregiver or parent. And it can appear as soon as the first tooth erupts, and the severe form can progress rapidly. It has very lasting detrimental impacts, not only on the child, but on the family, the community, and health system. On the child, child can be in severe pain, can cause malnutrition, sleepless nights. It can affect the child's development, and early tooth loss can lead to malocclusion and school absences. In the family, it's like a form of guilt. Parents feel guilty for their children having caries. And also there's loss of economic time. In the communities, the teachers have to accommodate absences, school absences in the children. And the healthcare system can have a high burden when we have children with early childhood caries. In Canada, the prevalence of early childhood caries is as high as 89%, especially in disadvantaged populations. The cost of surgery to treat severe early childhood caries exceeds over $21 million yearly, while early childhood caries is preventable. Dental surgery rates are higher in children living in rural regions and from low-income households and Indigenous communities. There are many recommendations to reduce risk of early childhood caries, according to many societies and institutions. Recommendations include combined efforts in some disciplinary approach, collaborative efforts with primary care providers to reduce the risk of early childhood caries. And this is because infants and toddlers are more likely to see the primary care provider than a dentist within the first 3 years of life. And it is because these primary healthcare providers are well positioned to give preventive oral health care to children, because children have an average of 6 well-child visits by the age of 1. And therefore, this positions these healthcare providers to see these patients and refer to the dentist for comprehensive care. It's also recommended that children should have established a dental home by age 12 months. Unfortunately, according to reports, less than 1% of children have seen the dentist by the age of 1. Timely caries risk assessment is recommended. Preventive counseling of parents and appropriate therapeutic interventions such as fluoride application, SDF, are some of the recommendations to reduce the risk of early childhood caries. The U.S. Preventive Services Task Force recommends that primary care providers should apply fluoride varnish to primary teeth of all infants as soon as their primary teeth begin to erupt. The American Academy of Pediatrics also recommends that pediatricians should conduct oral health risk assessment for all children at every routine well-child visit, starting at 6 months of age. The Surgeon General's report in 2000 on oral health in America underscores the importance of integrating oral health into primary care. So many bodies have recommended and see the importance of integrating oral health of children into primary care. The American Medical Association established a procedural code for application of fluoride varnish by primary care providers, and also an SDF code for primary care providers. In Canada, the Canadian National Oral Health Research Strategy, which was launched in 2024, recommends evaluating research strategies that integrate oral health care with primary medical care. The Canadian Dental Association recommends a multidisciplinary approach to controlling early childhood caries. And they also agree for timely caries risk assessment is an important first step to reduce the risk for early childhood caries. And this is because it places emphasis on intervention before the irreversible damage occurs. So this brings me to what do we know as caries risk assessment? Caries risk assessment is the determination of the likelihood of caries to develop or progress over time. It involves identification, analysis of certain factors that are related to dental caries. For example, protective factors such as presence of use of fluoride or presence of fluoride in water, community water, risk factors such as the presence of caries or other social economic factors like low income. It does not stop at identification. It also aids the provider to propose and provide personalized preventive care and therapeutic strategies to reduce the risk of caries in children. And several dental and pediatric organizations have developed caries risk assessment tools. Examples are the ADA tool, the Canberra, the Cariogram, which we're not going to be talking about all that today. But I want to bring our attention to the Canadian Caries Risk Assessment Tool for preschoolers, which was developed by the University of Manitoba research team in collaboration with Public Health Agency of Canada. I will just give us a brief history of how this came about. So in 2017, the Office of the Chief Dental Officer of Canada and PHC contacted the University of Manitoba team, which is led by Dr. Robert Schroth, to undertake the CRA project and to develop the CRA tool for preschoolers. This started by undergoing a systematic review to draft the CRA tool. The CRA tool was then drafted and was reviewed by stakeholders, and the feedback from the reviews were used to also to redraft the CRA tool. And in 2018, a trial was done among non-dental primary care providers. And in 2019, this was translated to French, and it was endorsed in 2020 by the Canadian Academy of Pediatric Dentistry, the Canadian Association of Public Health Dentistry, and Canadian Pediatric Society. And this was launched online in 2020, and it's now included in the Rock Baby record. And some provinces are now have implemented the CRE tool. So the Canadian CRE tool allows not only dentists or oral healthcare providers, but it allows non-dental primary care providers to assess the risk of caries of children. It helps them to take some defined initial action on tooth decay, and also prompts them to refer the children to dental providers to establish the dental home and to apply fluoride varnish for the children, those who have high risk. So this is what the tool looks like. If you look into the chat box, you will see some of the links where you can look at what the Canadian Caries Risk Assessment tool is like for those who are not familiar with the tool. The tool has a series of questions that helps to identify the risk of a child, and it also has some recommendations for the parents and dietary counseling, and also it prompts the provider to apply fluoride varnish. The beauty of this tool is that it also has some pictorial aspects of it, where it shows non-dentists what visible plaques look like, white chalk lesions, and advanced caries, what it all looks like. So after the calculation, it helps the provider to place the child at either low risk or high risk. A child is said to have low risk if all the scores are below 3, and if a child scores 3 or greater than 3, then that child is at risk of having caries. So today I'll be talking about the findings from our project, my project titled Determination of the Strategies for Implementing and Integrating the Canadian Caries Risk Assessment Tool for Preschoolers into Primary Care of Indigenous Children in Manitoba. And the objectives include to identify non-dental primary care providers' perceived barriers, training needs, and facilitators, so including CRA in primary care of First Nation and Métis preschoolers in Manitoba. And then secondly is to train these non-dental primary care providers in the use of the CRA tool and determine their acceptability to increase familiarity and clinical use of the tool. 3 is to develop a guideline for training, implementation, and integrating the CRA tool into primary care of First Nation and Métis children. So this study started in April 2023, and it was a qualitative study that adopted a social constructivist research paradigm. Data was collected through 8 focus group interviews, 10 key informant interviews, and participants were non-dental primary care providers in Manitoba. Participants were purposely selected from 10 Indigenous communities. I mentioned a few of them there on the screen. We have Sell Creek, St. Laurent, Swan River, Pine Creek, Camperville, Pine Falls, Thompson, and St. Teresa Point. As some of the Indigenous communities that we traveled to, the eligibility criteria to be a participant had to be a non-dental primary care provider providing care for Indigenous children below the age of 6 years. Participants were recruited through flyers, social media, word of mouth, and through the Ongomism Health Services, and from the list of pediatricians at the University of Manitoba. Data was collected via a semi-structured interview, and interviews lasted between 45 to 75 minutes. They were audio recorded, coded, and thematic analysis was done using NVivo. So these are the findings. We had 50 participants and were involved in the study, and this included pediatricians, family physicians, nurse practitioners, public health nurses, physician assistants, child development workers, dietitian. Majority of the participants were public health nurses, and the mean age of experience was 12 years, and most of them were females. So one of the questions that we asked the participants was, the CRA tool, do you find it to be advantageous in your communities? And this were the findings. This was what they said. They said they found the CRA tool to be beneficial. One was it can improve the quality of life of the children. It can aid access to dental funds. And we know that recently the government just started the funding for public health dental coverage for those with low income, the interim Canada dental benefit, and the Canadian dental care plan is ongoing right now. And this tool can be as a pointer to prompt the healthcare providers for children to access these funds. It's also said that this tool can improve access to dental care. It is factual and evidence-based. It is preventative. It can reduce the risk for surgery. It will prompt the healthcare providers to give oral health counseling to parents, and it could be cost-effective in the long run. As said by one of the participants, I read and quote, sometimes parents might not know that caries can be really painful, and losing their child's baby teeth prematurely affects permanent teeth. This tool could really help to improve the quality of life for children in general. It's so much more than having spots on your teeth. So another question that was asked the participants was, what are the barriers and what barriers do they perceive or think will prevent or will be challenging to implementation of the Canadian Caries Risk Assessment tool and integrating into the oral care of primary care of Indigenous children. So they mentioned, this was grouped into knowledge barriers, child barrier, carer barrier, community barriers, and service barriers. So I'll start with the knowledge, the service barriers. This participant mentioned that lack of funding may prevent the use of tool because this tool prompts them to use, apply fluoride, and they would need funding for fluoride. Some saw it as an additional workload. There could be time pressure as most of the providers have less than 20 minutes to see a patient. Lack of recognition. A few of them mentioned that they collaborate with other providers, but there's lack of recognition for the work that they do in the communities. Some mentioned that CRA is not within job scope, but as I said earlier, there's a lot of recommendation that primary care providers are recommended to provide initial preventive oral health care for children. Other competing illnesses could be a barrier as well. We also have barriers, community barriers. There's low oral health awareness in the barriers, in the communities. Normalization of caries is high in the communities. And what is seen as normalization of caries could just be that it's a low awareness, not being aware of how to prevent this caries in children. And also sometimes the stainless steel crown is seen as a rite of passage in some of these communities. Transportation is a barrier because the tool prompts the dental provider to refer these patients to the dental clinic. And some of these communities do not have dental clinics. They have to travel to Winnipeg, 5 hours, 6 hours to get surgery done. Low income, food insecurity are some barriers because the tool prompts the providers to give dietary counseling. And we know that food insecurity is prevalent in some of these communities, and the cariogenic food are cheaper, and therefore they are able to get those ones. Generational trauma, dental care being separate from general care is another barrier mentioned. Career barriers include parents feeling judged, having bad experience with the healthcare system, parental willingness, personal beliefs about dental care, fluoride are some of the barriers mentioned by these participants. Knowledge barriers include lack of skills on application of fluoride, child management, lack of skills and screening for cavities, and not having the list of dentists who are willing and ready to take publicly funded patients. And also they need to have more knowledge on oral health provision. Child disability, child being not cooperative, lack of childcare supports are some other barriers that are mentioned by the healthcare providers. I read and I quote according to one of these participants, we need a lot of education on how to screen for that, referring to caries, as well as we also want to see better access to professional screeners, referring to hygienists. So it's great to say we are going to do it, that is do the CRA assessment, caries risk assessment, but if time is not made to be able to do it, it's going to be tough. What are some of the facilitators? Because some of the questions we asked was, what do you have or what can facilitate the use of this Canadian Caries Risk Assessment tool? As mentioned by the participant, caries being endemic in the communities will aid them to implement and integrate the tool into the primary care of these children. They found the tool to be simple to use. The primary care providers already have existing relationships with families, such as family first programs, having existing health start programs. Nurses already practicing some form of CRA, though informally, they check the children's mouth, but do not have the tool a formal tool. Having professional screeners, dental hygienists, having a list of dentists who are willing to take publicly funded children, and also having existing clinics and facilities will facilitate the implementation of the tool. So not just the barriers, the providers also mention some strategies that will help to implement and to integrate the caries risk assessment into primary care of Indigenous children. And one was education. We need to continue to educate parents. There's still low awareness in some of the communities. Though we have our Happy Child, Healthy Smile Happy Child initiative, which has a lot of resources. If you check in the chat box, we have links that can point, you can point everyone here that's listening to look at some of our resources that we have on YouTube, Instagram, and social media. We have quite a lot of resources, but we need to create more awareness for the communities and the primary care providers to see these resources. Dissemination of information that supports dental care in primary care in medical setting is also important, so that the patients, the parents, and carers know that nurses and doctors can give preventive oral health care in medical settings. Communications can be done via social media. A lot of the Indigenous communities have, you can reach them through social media. Building trust in the community is very important. There's some lack of trust in the health system. We need to build the trust. Dentists, the oral healthcare providers need to train in culturally safe dental care. Provision of oral health supplies that can aid compliance are important in these communities. Sometimes what seems like lack of compliance is just the fact that they do not have the resources to purchase the dental supplies, toothbrushes, and toothpaste. Policies that support transportations are needed, and also integration of CRA into Head Start School and already existing community events are recommended. Training on how to use the CRA tool on preventive oral health care for children in general is recommended. Getting approval of managers, health managers, and administrators, having a very clear referral pathway and documentation pathway is recommended by by the participants, and also integrating the Caries risk assessment tool into the electronic medical records will be helpful for the participants to implement this. Currently, we have it as a link in Babyrook where it can be printed out, but we hope that this tool can be part of the electronic medical record where it can be checked as a list and easy to implement. Also, policies that support sugar reduction in products, fee for service and funding for non-dental primary care providers, CRA being well defined in job scope, getting buy-in of administrators, and integrating this CRA tool in well child visits and family first programs are also part of the recommendations given by the healthcare providers. I read and I quote according to one of the participants. And regarding fluoride, I would definitely say we will want more training and maybe tips on how to get a kid to keep their mouth. It can be very hard to keep their mouth open long enough for me to put fluoride. I would definitely like some tips and tricks on how you guys manage that. I am really good at getting them needles. Definitely we want some training about fluoride application. I think that's why it's a good one, referring to the CRA tool, because it looks like it's focused on risk. Identifying those risk factors early and being able to put it in a format where healthcare providers start sounding the alarm early enough, according to a family's physician. According to Becky, a public health nurse, yes, it will be beneficial, preventing a lot of issues, pain for children, and prevent a lot of potentially unnecessary trips to Winnipeg and referrals. I'll just read a few more quotes. When I was training, this was by a pediatrician, they were saying 25% of oral time is being picked up by kids in dental caries. And that's just wrong because it's a preventable disease. So certainly things can be done. I do think it will be important to have dentists that are on board with receiving referrals from public health for those people and understanding that it's coming from public health. And that's where we're working holistically with the patient. Maybe it's a fee-for-service billing code. So if a physician is doing this as part of the assessment for a well child, they can be remunerated for their time for providing service. If they started including this with our charts and we are told to try and get this done, I would. I guess that's basically if I'm told to. I have to, then I would. Yeah, so this bringing me to the end of the talk today. The findings of our research has been spoken and in different conferences at the Children's Hospital Research Days, at the Manitoba Dental Association, at the Canadian Oral Health Summit that was this year, at the IADR New Orleans, and also it's been said here at Healthy Smile Happy Child. We also have a presentation at IMAGE coming up next year, and we continue to say this so that we have support and policymakers can listen to this and maybe put some policies together that we aid the implementation and integration of the Canadian Caries Risk Assessment Tool into primary care of Indigenous children. So what's the take-home message for today? Children in Indigenous communities have great burden of dental disease due to poor access to care and unique challenges. The Canadian Caries Risk Assessment Tool for preschoolers is a promising approach to early preventive dental care. There's need for collaboration with non-dental primary care providers for early access to preventive oral health services. Their views and experiences are important in implementing caries assessment for children in Indigenous communities. Future directions will be to determine the views of the end users, the parents, the primary care providers on integrating CRA into the primary care of their children. And two is to determine the training needs and train the non-dental primary care providers on caries risk assessment. So this brings me to the end of my presentation. I would like to thank all our funders on behalf of Dr. Robert Schroth and the team, the research lab, to thank all those that have funded, continues to fund our projects. There's a lot of, but it's on the screen right now. And last but not the least, I wish to thank my supervisor, Dr. Robert Schroth, who brought me to Canada exactly 3 years ago this month, and for creating the enabling environment to carry out my research. I wish to thank all the research team as well, to thank Daniela, the coordinator of the Healthy Smile Happy Child initiative, and every member of the lab for the teamwork. Thank you very much.